Okay, everybody. Hello. This is a talk that I gave just a few days ago to the Canine, the Police Canine magazine. They have a conference at least once, sometimes twice a year. One of those times is always in Las Vegas, and for the past few years, I've been giving this talk. It's volunteer, just to help the law enforcement community who work with canines and the military working dog um, soldiers and their trainers as well. So, gunshot wounds in dogs. This talk, when I gave it, did not record, unfortunately, on my computer. So, we are doing it now, and we'll just go through it. And any details that you want will be in the description below. So, for those who have any questions, this is my contact information, my social media, and my email address. This is my background. I won't go into this. This is common knowledge for those who follow the channel, and it's on the Vet Triage website as well. This is the outline that we're going to tackle here. We're going to start with general incidence of gunshot wounds, how the pandemic plays a role in the incidence of that kind of trauma, animal abuse and its role with gunshot wounds, the patients that are most commonly affected, the timing of these incidences, the geographics and locations behind it, how joint trauma is an important aspect to this in human medicine, maybe not as much in animals, and that leads us nicely into lead poisoning, which again is more of a concern on the human side, but we'll talk about it. And then different thoracic traumas that you can see, hemothorax, pyothorax, pneumothorax, how to perform a thoracocentesis, and then also what the veterinarians will perform, which is thoracostomy tube placement. Diaphragmatic hernia is another thoracic trauma that you can see. I did not go into abdominal causes of trauma. Those tend to be not as big of an emergency per se, although of course they can be. And I wanted to focus on the more immediate life-threatening aspects of this for those dogs that are at risk of gunshot wounds. And then how we go into scoring and prognosis based on literature, survival and hospitalization, wound characteristics, and finally treatment. This talk is geared towards officers and dog trainers, military personnel, so it doesn't go into the nitty-gritty of the clinical side as much as maybe some folks would want, but the point still remains. You can get a lot of information out of this anyway. General incidents, so projectile injuries in general. Cruelty makes up about 14% of such injuries in dogs. Trauma, less than 2%. And the trauma types, motor vehicles, of course, are probably the most common type of injury we see in the veterinary space, so hit by cars, and then bite wounds, altercations with other animals, whether it be domestic or wildlife. Firearms can range between 0.8% to 2.1% or 3.6 gunshot cases per year. And we did see with the pandemic a rise in gun ownership as well as the incidence of gunshot wounds in animals and in people increasing in both urban and rural areas during the pandemic. So the COVID-19 pandemic did have its influences fairly significantly on the incidence of gunshot wounds in humans and in animals. The coronavirus disease of 2019, due to probably stay-at-home orders and the mental and emotional toll it took on people, we saw an increased number of firearm background checks, increased number of firearm sales, 3 million more guns purchased, rise in gun violence by 77.8%. And the admissions into hospitals for gunshot wounds did increase. Now, there was a decrease in the number of hospitalized patients from gunshot wounds, and the speculation there is that either that a lot of these gunshot wounds could be managed in people as an outpatient, or that the number of beds were very limited and oftentimes at capacity in human hospitals, not just because of severe gunshot wounds, but because of diseases pertaining to COVID-19. And so that may be a reason why the admissions went up, but the total number of hospital cases actually went down. And gunshot wounds cases increased by 77.8%. So pre-pandemic, most of the injuries that we saw in dogs made up the extremities of 55%. And then interestingly, post-pandemic, most injuries then became in the face to dogs, so maxillofacial injuries, 56%, and then an increased number of gunshot wounds were seen in companion animals. So there was a rise not just in people but also in animals in terms of these types of trauma. The concerns of animal abuse are dealt with by not just veterinarians but law enforcement agencies and society in general. We've all seen those social media clips of cases of animal abuse, whether it be due to abandonment or trauma or what have you. And so cruelty has become much more well known in society in general because the internet has made it where you can post about abusers of animals quite quickly online, and social media just spreads that information rapidly. As far as post-mortem examination, which is where unfortunately a lot of times the evidence is going to be collected from suspected animal abuse cases, this involves veterinary forensic pathologists, public agencies, and animal protection centers as well. Ideally, obviously, you want to catch animal abuse before the animal perishes, but unfortunately, it's just not the reality of it. So with post-mortem examinations, when you look at the literature in dogs, blunt force trauma makes up the majority, almost 50%. Firearm injuries are next in line at 18%, and then asphyxiation at 9%, heat stroke 5%, starvation 3%, and then a combination of bite injury and sharp force trauma 1.82% each. Cats, blunt force trauma is the highest, followed by firearms and bite injuries. And so you can see, of course, hit by car probably is the majority of blunt force trauma, maybe jumping out of a window or off of a deck, but firearms are second in dogs and cats. So as far as what patients are affected by gunshot wounds in dogs and cats, they tend to be on the younger side, 3.4 years of age for the median, average 3.2, and most often males. And the theory here is that younger animals tend to be more curious, they're exploring more, they are more rambunctious, they get into trouble. And so they tend to be younger animals, and then males especially are known for being a bit more adventurous than the females in general, and so they are more likely to get in trouble as well. And plus, and the reason why they're more curious out in the field is not only because they are seeking females if they're intact males, which you can see there makes up 40%, but also they tend to be a bit more territorial, more aggressive than females in general. So males make up the majority of these cases. Of the dogs, most are working breeds. And obviously, if you compare dogs to cats, dogs are way more commonly affected by trauma in general than cats are. But working breeds are the target audience for this talk. Military working dogs, canine officers, and so they make up the majority of the dog breeds that are affected. Working and hunting dogs in combination make up a large population as well. Pit bull types more often, 42%, mixed breed 30%, Labradors, and then from there. And most often, if there's a working or hunting dog breed that is injured from a gunshot wound, they are probably from a rural area, whereas the non-working dog breeds involved with gunshot injuries typically come from more urban areas. So gunshot wounds can occur throughout the year, that's obvious, but we do see some level of predominance towards the autumn months, so September, October, November, followed by winter, then spring, then summer. And then as far as when gunshot wounds happen during the day, unknown 60% of the time, which, of course, folks who are involved with this type of dog injury are not going to disclose that information readily, and so a lot of times you don't know when the injury occurred. Otherwise, after unknown, 6 p.m. to 6 a.m., and then twilight hours, low visibility hours. During hunting excursions, which is another reason why young male canines are implicated in these injuries, because they are the ones that also tend to be taken out hunting, and so you can have accidents there. And location, you often see it in lower income urban and suburban areas. So urban, 59.5%, and of the urban geographics, most of the time handguns are involved, whereas in the rural regions at 40.5%, most often rifles and shotguns. No surprise that most of these injuries are unwitnessed, 62 to 80%. Of those that are witnessed, it could be reported owners of the animal or neighbors of the animal are most often, but also hunting excursions, roaming property near the residencies are also risk factors, but most often it's going to be either the pet owner or a nearby neighbor. Handguns make up 23 to 50%, shotguns 42 to 77%. Other types like air guns make up a lower percentage, unknown, and 14%. So this picture here shows that there's actually characteristic exit wounds, type wounds and exit wounds, both internally and externally, depending on what kind of gun you're talking about. So that's pretty interesting, and that also helps with forensics. In the urban areas, we see more higher incidence of head and neck wounds, whereas in rural areas, we see a higher incidence of non-fatal extremity wounds. Overall, limb injuries to dogs make up 32 to 43% of injuries. Thoracic limbs more common than pelvic limbs. The actual thorax being injured with a gunshot injury, 21 to 26%. Head and neck, 14 to 16%. Head or neck, 16% each. Abdomen, 11 to 14%. Vertebral column, 3%. More than one location, 19%. Here's another picture of the different bullet types and how they are characteristic in terms of their trauma to the soft tissues. Pre-pandemic, we saw more injuries, like we said, in the extremities, 55%, followed by thoracic, spine, abdominal, facial, and cervical. But then during the pandemic, facial went up at 56%, cervical 43%, extremities got cut by half. So clearly there was a distinction there, and again, probably due to the emotional and mental toll with folks being forced to stay at home for quarantine. Now, joint trauma is a big deal in people, less so in animals. Joint trauma usually involves, in this case, intra-articular foreign bodies. However, if you look at the literature, it's quite rare in dogs. There's been one report of a tooth in a dog's joint, a porcupine quill in another dog, bullet fragments in another, and then a horse with lead pellets. So not very common at all. Now, it may just be that dogs are more resilient than people, and so if it doesn't affect their functionality, they don't see the vet, or it could be that trauma like this is hidden from the veterinarians, and that's why we don't see it that often. But anyway, based on literature, it's rare. Radiographs are used to diagnose the condition, and you have to figure out from radiographs whether or not these fragments or any foreign body in the joint is actually in the joint, meaning intra-articular, or around the joint, periarticular. There is a difference, of course, in anatomic location between the two, and perhaps a difference in significance as well. You can guess that we care more about intra-articular trauma than periarticular in general. Ultrasound and arthroscopy are also other imaging modalities that can be used in dogs of these cases. Lead toxicosis in animals is rare and has a multifactorial causality to the patients that are affected with a lead toxicosis. It can cause a chemical issue, a mechanical issue, osteoarthritis long term, and of course systemic lead absorption are all sequelae from lead toxicosis. And lead toxicity doesn't just come from gunshot wounds. Anything made of lead, of course, can predispose them to this. So we're going to go through here radiographs. Now I can't use a pointer for the way we're recording this, so I'll try my best to describe things. On the left, where it says right and left, that's a ventrodorsal image of a dog. So this dog is laying on their back. The top of your screen is where the head would be. The bottom of the screen is the tail. And you can see two bullet-shaped fragments, one within the heart silhouette there, and then the bottom fragment is in the abdominal cavity. And and then on the right side is a zooming in of the heart with the bullet fragment. Now, you may think that this bullet fragment is located in the actual heart, but because this is only one view, meaning it's a flat image, you need the other view. We call that an orthogonal view. We need the orthogonal image to make sure that this bullet fragment is actually in the heart. And I'm willing to bet it's not in the heart, because if it were, you would have, first of all, the dog probably would have died on impact. But anyway, you would have had hemothorax, pneumothorax, some sort of thoracic injury on the radiographs, but these radiographs are showing completely normal lung fields. So you need the other view. For the abdomen, the same thing. You may look at that bullet in the abdomen and say, okay, that might be in the liver, might be in the stomach, small intestine, it might be in the pancreas, but we don't really know until you get the other view. It is very likely that or it is a possibility that that bone fragment or that bullet fragment is somewhere else in the dog, not affecting major organs, most often in the muscles or skin or fatty tissue of that animal. So here is a side view of a dog with a bullet fragment. This side is where the dog's head is going to be. This side is where the tail is going to be. This dog is laying on their side, and so you can see that bullet fragment again. It's right at the caudal aspect of the cardiac silhouette. It's in the area of the lungs, affecting the larger lower airways. And same thing. It looks like it might be in the actual chest, but you don't know if it's in the chest, and if it is in the chest, you don't really know what organs are traumatized by it, because you need the orthogonal view in order to figure that out. And I would probably doubt that this animal has any intrathoracic trauma from this bullet. However, towards the bottom there, underneath the windpipe, there may be some fluid in between the lung lobes there. And maybe caudally, like right below me here, but it's hard to say because you don't have the entire thoracic view here, and so that also could be just fat in this animal as well. So it's very important to get both views. Another example here, this looks like a cat, and the tail would be this way, head that way. You can see that bullet fragment in the abdominal cavity, and is it affecting any organs? We don't really know. We need the other view to make sure. On this radiograph, the head is that way, tail is this way, and this is another animal on its side. And you can see there a whole bunch of bullet fragments, not just around the spine, but also in the abdomen there, where it says there are LAT, right lateral. And so we have to figure out which one of these fragments do we care about. It is often the case that we're not going to surgically remove every single fragment that we see. We tend to remove fragments only if we think it's going to cause a problem, meaning it's in the joint or it's affecting a major organ or blood vessel, or we need bullet fragments for evidence purposes from law enforcement. And so otherwise, if it's not affecting the animal, although this looks pretty scary, it won't be something that a surgeon is going to pursue. You can also see up top there at the very top of the spine, in line with my finger, there's gas opacities within the subcutaneous tissue of this animal, and that tells me that this trauma was actually recent. This just happened. There are gas opacities that indicate a disruption of the tissue planes in the dorsal cervical region, the interscapular region, and dorsal to all the spinous processes, as well as some of the lumbar processes there. Here's a skull of a dog, and it's obvious. You can see all the bullet fragments. Same thing. We don't know whether or not these bullet fragments are affecting anything of note. We would need the other view, and in fact, with skull radiographs, you typically need more than just two views. Unlike thoracic and abdominal, typically two views is enough. But for skull, you're probably going to have at least three, if not more, views to figure out where all of these bullets fragments are located in this animal. Here's a picture of a stifle of a knee, and you can see all of that looks like stars or dust. That's all bullet fragments from whatever weapon. I'm not familiar with the types, but it just shows you how it can be very tricky to tell whether or not these fragments are actually in the joint of the stifle or around the joint, and it goes down to the ankle as well, as you can see down below. So it's difficult. I can't tell whether or not that thigh is swollen or not. But I don't see any disruption of the soft tissues like we did in that other view, although maybe above the patella there might be, but it's hard to say just from this one image. Here is a dog pelvic radiograph. The head would be up top, tail is down below. You can see the tail there actually. That's the pelvis. And then that femur on the right side is shattered. And so you can see bullet fragments there. You also can see bullet fragments by the tail region, caudal to the pelvis. And obviously, this is a severe trauma. You can tell it's high velocity trauma based on how many fragments of bone there are there in that femur, and there are bullet fragments there, which tell you that obviously this is a high velocity impact. And so if we can retrieve those bullet fragments for evidence, then we will. Otherwise, it's not a priority to us. We're looking to reconstruct the femur. Here's a cat with a fractured humerus. You can see there the humerus is shattered. I don't see any obvious bullet fragments here, although it's possible because cats are thin, lean muscled, and this is obviously a high velocity impact. It could have been that the bullet, if it is a bullet, went through the femur or the humerus rather, and then exited the soft tissues. So that's maybe why you don't see any fragments. Or this could be a fracture for any other reason, just trauma or whatever else. But the point is that there's a high velocity impact here of this humerus. Here's a cat with multiple bullet fragments. One is located down below here in the thoracic spinous process region, and then you can see, of course, in the skull. Again, you would need the other view to figure out where these are actually located. But this is a cat with bullet holes, and then these images now are just meant to show folks that other things can show up as metal, not just bullets, of course. So this is a screw that a dog ingested, and it's probably in the stomach, although I can't tell for sure if it's in the transverse colon, but I have a feeling the colon is just caudal to it, and this is probably in the stomach. So you can see interesting things like that. This is an egg that the dog has ingested, and you can see with the head being this way, tail being this way, it's pretty far down in the intestinal tract to the front part, the smaller edge of that rock. Those intestinal loops are dilated, so is the stomach. The stomach is filled with fluid and gas. So that tells me that the rock got far, but then ended up getting lodged somewhere. Probably the ileocecal-colic junction, because the lumen of the small intestines, where it becomes large intestine, is quite narrow. That sphincter, but it doesn't really matter. This seems like this is an obvious obstruction, and this dog probably does need surgery to have the rock removed. Here's an insane photo of a dog that's ingested a knife, and so you can see the entire metal part, and you also can see the outline of the wooden part of that knife. Whether it's caused other issues or if it's simply an obstruction, it's hard to say. I would imagine by looking at these radiographs, it's not the greatest view, and you need the other view as well. But based on the fact that there's no fluid in this chest, makes me think that this is sitting quite nicely in the distal esophagus, going through the distal esophageal sphincter into the stomach, and so you need surgery, of course, to remove that. And this was a trick question during the lecture. You can see there by the diaphragm where the liver and stomach would be. There's two tiny pinpoint fragments there of metal. Whether or not those are rocks or bullet fragments, not really sure. It could also be mineralization in the liver, in the gallbladder, lymph nodes, small intestine, large intestine. But there's two tiny fragments there, and then of course there's these massive boulders right there in the region of the caudal abdomen. And I asked the audience what these are. They of course guessed rocks, but they would be fairly unlikely that a dog of this size would ingest rocks that big, especially two of them, and those rocks would have traveled that far down the abdomen, and they're not causing any evidence of obstruction in front of the rocks, cranially too, like we did with the other one. Those are actually bladder stones that we're seeing there. Two very large bladder stones, which makes more sense. They're in the area of the bladder, they're nice and smooth, which a lot of bladder stones are, not always, but they are. But this does make more sense. So lead poisoning causes cellular trauma, sulfhydryl containing enzymes, thiol content of erythrocytes, antioxidant defenses, and tissues rich in mitochondria are all affected by lead poisoning. Capillary damage can occur where you can see bleeding in the brain and edema in the brain. It also is immunosuppressive, gametotoxic, so toxic to the gametes or reproductive organs. Teratogenic, meaning can cause cancer. Nephrotoxic, meaning it's toxic to the kidneys. And it can affect the hemopoietic system as well, which is the part of the body that makes red blood cells, white blood cells, platelets. And so this x-ray is a front view of the stifle of a dog, and you can see that there's bullet fragments, or at least metal fragments of some kind, maybe bullet, maybe not. But it's suspicious that some of those are probably in the actual joint. But again, you need the other view to make sure that they are actually in the joint or not. So the theory is that if you leave these fragments in, will this dog get lead poisoning? And it turns out in animals, it's not very common, or at least not reported in the literature that much. Lead poisoning can cause gastrointestinal abnormalities like anorexia, colic. Sure here. Make sure we're still recording. Colic, vomiting, diarrhea, constipation. And it can also affect the central nervous system with anxiety, hysterical barking, jaw chomping, that should be, salivation, blindness, ataxia, muscle spasms, opisthotonus, and convulsions. For those who have never seen opisthotonus before, these images, one of a dog, a foal, and a calf, are all in opisthotonus. And so they are aware of what's going on, but their body, the nervous system, is stuck in external or in extensor rigidity, and so their joints are extended, their head is extended. And if you try to move the joints, it'd be very hard to actually flex and extend those joints. They're stuck in extension. But keep in mind, there are many other diseases that can cause central nervous system signs like this. Rabies, for example, is one of them as well. So if you see this in animals, it doesn't necessarily indicate a toxicity of lead, or any toxicity for that matter. You can have this problem with a severe cervical injury as well, and or even a brain injury. So lead poisoning is just one example. Now, when we talk about pleural disease, we're going to talk about three basic ones that you often see with trauma: hemothorax, pyothorax, and pneumothorax. This is a lateral view of a dog where the head is that way, tail would be this way, and those lungs are being lifted up off the sternum because there's fluid around the lungs. And here's a comparison. On that side, the left side, that's a normal chest, and on this side, there's fluid, and so you can see the difference there. You can barely even see the heart in this view. The lungs are elevated. There's all that grayish material, gray-white material, and that's fluid in the lungs. Whether that fluid is due to blood or infected fluid or whatever, we don't really know from the views, but it's just to show you. And then again, on that side is a normal chest of a dog. It's on their back, head is upwards, tail is downwards. And then on this side, you can barely see the heart. The silhouette is being covered by fluid. And the lungs, you can see the lung lobes there. Also, they're outlined pretty nicely there. All fluid around the lung lobes as well. The reason why you can't see the heart in this image is because when the dogs are on their back on the radiology table, the X-ray table, that fluid is going to funnel into the spinal gutter, and so it ends up being right in midline where it'll cover the heart. Hemothorax is blood in the chest. It is defined as having a hematocrit of 25 to 50% greater than peripheral blood, and it can be due to trauma, either blunt or penetrating, but there's a whole host of other causes of hemothorax in dogs and cats: malignancy, pulmonary embolism, coagulopathy, diaphragmatic hernia, thymic hemorrhage. So thymic is the thymus, which is an organ in young animals, dogs and cats. That is the primary organ to produce immunoglobulins and white blood cells. And then as the animal reaches maturity, the thymus usually involutes. Lung lobe torsion, heartworm infection, and iatrogenic causes. And so these are both necropsies of animals. They're no longer with us, but you can see the blood surrounding the lung tissue in the chest. Pyothorax is infection in the chest, purulent exudate within the thoracic cavity, most often due to migrating inhaled foreign bodies, can be due to thoracic trauma. It could also be due to pneumonia, lung abscess, parasites, esophageal or tracheal perforations, infection of the discs and vertebral bodies of the spine, so discospondilitis, cancer, iatrogenic. That's an image there of an animal that has a tube sticking out the chest, and you can see that very thick, high viscosity, bloody looking fluid. You might think it's blood, which it could be, of course, but the reason why I picked this image, because it kind of has a very thickened gelatinous appearance to it, which is pretty typical of infection or pus in the chest. This is an example not necessarily of pyothorax, but this is just showing a lung lobectomy. That's a stapling device being used. The surgeon is holding up the lung lobe, and there's a tumor there in the center of the lung lobe, and so that's how we will remove lung tumors, for example. So pyothorax is usually seen in young adult hunting dogs. They're working breeds. Survival 78%. With surgery after 1 year, medical treatment alone 25%. So most often you are trying to perform surgery on these animals. You have to just figure out where the source of the infection is. Pneumothorax is by far the most common. It's more common than hemothorax and more common than pyothorax. This is when there's air within the thoracic cavity, but outside the airways, outside the lung and the airways. So it's within that. It's in the pleural cavity, which is that thin Normally a thin space in between the chest cavity and the thoracic organs. So you can have pneumothorax defined as being open or closed. Open is due to an insult to the thoracic wall, usually due to penetrating thoracic trauma like gunshot wounds, stab wounds, bite wounds. And closed trauma, or closed pneumothorax rather, is due to trauma to the thoracic cavity where the thoracic cavity is intact. So the air is not coming from the external environment like with open pneumothorax. It's coming from within the thoracic cavity, so it comes from the lung, trachea, lower airways, esophagus, mediastinum, and diaphragm. This image below, if you notice, the heart looks lifted off the sternum, and the lungs look much darker around the edges than the previous radiographs. That's because it's all lung tissue in the pleural space, and that air that's building up outside the lungs is compressing the lungs, causing consolidation. That's why around the heart area down below, it looks like electricity or something coming out. That's lungs that are being collapsed. And beyond that collapsed lung is just that sort of the smoother black appearance, that's air. So here is a comparison. The x-ray over there is a normal thoracic cavity in a dog, side view. And then down below here is, you can see the heart is lifted. There is a glassy black appearance around the heart, and those lungs are consolidated, retracting from the thoracic wall because the pleural space is being filled with air. This is the a ventrodorsal view. So on that side there is a normal chest, head is up top, tail down below, and then on this image below me, you can see that it looks a bit more foggy. It's probably more of just the image itself, but the heart doesn't look as crisp on the edges, and you can see the around the lungs down below, there's almost like a triangle shape there, the caudal rib cage. And that's air. That's air in the pleural cavity, causing consolidation, compression of the lung space. So pneumothorax can also be considered a tension pneumothorax. That's a type of pneumothorax, not related to the cause of it, like we described with open and closed. Tension pneumothorax is when there's air leakage and from a site, and it creates a one-way valve during inspiration, increasing pleural pressure. Every time that animal breathes in air, the air leaks into the chest cavity, but it has nowhere to escape because the site of the leakage is causing a one-way valve effect. So you have a very rapid buildup of air, much faster than your typical pneumothorax, because every time they breathe, which is going to be very common, especially in terms of like trauma and shock, the air is going to build up. So motor vehicle accidents are most common. 47% of dogs with tension pneumothorax were hit by car. But it could also be from projectile injury, bite wounds, penetrating sharp objects, and iatrogenic. These two x-rays, the smaller one is a side view of an animal, the head being that way, and the one below me is a ventrodorsal view with the head being above, and you can tell how the chest is kind of barrel shaped. You lose the scalloping between the rib cages of the lung field. So if you look on this image there, the normal image, you can tell as you go from rib to rib on the side of the chest cavity, it has a slightly scalloped appearance to it, whereas here it's very rounded. Now this is a sort of a trick, because this is actually not tension pneumothorax. This animal actually has the entire stomach is in the chest and it's filled up with air, and it's causing gastric bloat, severe gastric bloat in the chest cavity. But the idea remains the same. You get that like football or basketball type of appearance to the chest cavity. So thoracocentesis is placement of a needle in the chest cavity with the goal is to remove the contents that are in the pleural cavity, whether it be blood, air, infection, or what have you. And so you can see there, one person is holding the needle in place, the other person is drawing back in the syringe of like pinkish fluid. This is a three-way stopcock that's connecting the needle to the syringe. And usually the doctor is going to be managing the needle, where the technician or the assistant is managing the suction, because you have to be careful as you remove the fluid or air or whatever from the thoracic cavity, and you're being successful at it. The lungs are going to expand more, and so when they expand more, they're at risk of hitting your needle, and you can cause an iatrogenic pneumothorax. So you want to feel that. Once you feel that gentle scraping of the lung tissue against the needle, you need to back the needle out slowly so you can still remove more fluid or air, but you don't lacerate the lungs. Same thing goes with the heart. If you start to feel the heart against the very tip of the needle, you need to, of course, move back. Thoracostomy tubes or chest tubes are placed in surgery under sterile conditions where you would have a more permanent access to the thoracic cavity. So this chest tube stays in place until the doctor wants to remove it. Depending on the situation, that could be a few hours all the way to a few days or even longer, depending on what disease you are dealing with. And so there's the tube that is borrowed underneath the subcutaneous tissue before it enters the chest cavity, and then it's attached to usually through a stopcock and then some kind of a syringe. And then you have to secure that to the animal. Diaphragmatic hernia is another form of thoracic trauma, or rather diaphragmatic trauma. It's not maybe as common with bullet injuries, I imagine. It can be either congenital or acquired. Congenital means that they were born with it. Acquired is they developed it, and they can acquire it from blunt trauma like vehicular trauma, high-rise syndrome, which is jumping out of a building or off of a high deck, dog fighting or attacks, and iatrogenic. The organs that are most often herniated are typically liver. Liver sits right by the diaphragm, so it makes sense they would herniate the most often. But then stomach, small intestine, omentum, spleen. You want to ideally perform surgery within 24 hours of admission. It increases survival. With acute disease, acute diaphragmatic hernia, survival is 94%. Chronic has less of a success rate due to re-expansion pulmonary edema. So what will happen is if you develop diaphragmatic hernia, meaning you developed it acutely, and then you want to jump into surgery fairly quickly because the patient is at risk of decompensating if you wait too long. If you have a chronic diaphragmatic hernia, let's say the animal was born with it, it may be years before anybody identifies the hernia, years. And so with that comes scar tissue formation between the organs that are located now in the chest, from the abdomen to the chest cavity. Those adhesions are causing the abdominal organs to stick to the thoracic structures or thoracic wall, and also because of the chronic compression of blood vessels and lung tissue, the second you release that pressure by performing surgery to repair that hernia, all that blood flow, all that oxygen is actually bad for the body. It's going to cause free oxygen radicals and cause oxidative trauma to the blood vessels, organs, what have you, and these animals will decline pretty rapidly. They'll form what's called re-expansion pulmonary edema, meaning this is fluid in the lung tissue, not around it, in the lung tissue due to re-expansion, rapid re-expansion of the lungs and a sudden rush of blood and oxygen. So you have to be careful with chronic diaphragmatic hernias. I have treated both of these, acute and chronic, and I typically will put them on a diuretic for if they have a chronic history of diaphragmatic hernia. Sometimes I've even put them on a constant rate infusion of a diuretic, but nobody really knows how to adequately manage these cases. That's just through my experience. I've developed those recommendations. But and then in the image below, if you notice again, the dog's head is that way, tail will be this way, and where normally you'd see the heart and the lungs, you're seeing all that gas, right? It looks like worms in the thoracic cavity, and that's all small intestines. The small intestines are sitting in the thoracic cavity due to a hernia. Now, when you talk about severity scoring and prognosis in human trauma centers, because gunshot wounds are more common, they've developed the acute physiology and chronic health evaluation 2 scoring system, which is in that box there. And we don't really have this in animals, not that for any reason other than just no one's looked at it. We do have the modified Glasgow Coma Scale, which is used for head trauma in animals. And then there's this small animal coma scale as well from the Kirby and Brasmer categorization of trauma. It can categorize these animals as having mild, moderate, severe, non-life-threatening, or catastrophic severe, meaning life-threatening. But most often the ATT score is what's used in animals in the publications to assess how severe their trauma is. So, excuse me. So if you have a trauma to an animal and you want to figure out what's the prognosis, we'll try to use this ATT score to predict that. And based on a study in 1994, if you do use the ATT score, it can predict the need for surgery in those animals, the need for blood products, the duration of hospitalization stay, and the likelihood for survival. It gives you a cumulative score. 6 body system categories: perfusion, cardiac, respiratory, eye muscle, integument, neurologic, and skeletal. And then based on that score, you determine what the prognosis is going to be. So each graded on a scale of 0, which is least severe, to 3, which is most severe. Low is considered less than 4.5. So for example, injury to the extremities. High is over 4.5, which is associated with longer hospitalization, worse outcome, needing surgery, needing transfusions, and thoracic and abdominal injuries. So there's a modified ATT score there, and you can see the scoring system is cumulative, and you would measure the animal as objectively as you possibly can. That's why these scoring systems are great, because if you can monitor or measure objective items, then it gives you a pretty black and white view as far as prognosis. The downfall is very seldom are things actually black and white when it comes to medicine. There could be a lot of subjectivity, a lot of up for translation there. So it's not perfect, but it's the one scoring system. This is a system that we do have. And then it assesses trauma from gunshot, vehicular, bites, and uncategorized blunt trauma. So for those who've never seen a really busy intensive care unit in a hospital, that's an example there. There's a dog there in the center table attached to a bunch of things. And it's tough. The staff have to manage a bunch of sick and injured animals, and an animal like that who's on a ventilator on the center table needs 24/7 surveillance with at least one nurse. And it's seldom that a hospital can actually allocate one person to the dog entirely. So they are relying heavily on monitoring in critical cases like that. With trauma in general, survival is between 66 to 86%. Those that die can be a third or less. Most often, deaths are due to handguns. There's no differences in survival when you compare it to injury location, hospitalization duration, cost of care, and firearm type. Outpatients are 49% of these animals, and an average hospitalization time of 5.6 days is what you see. But this is, of course, all subject to the type of study that you're performing. So wound characteristics, there's a lot of studies on this. Most often they're experimental, they're not clinical. But the form and size of gunshot wounds depends on the projectile type, the caliber, the range, and velocity. Now, the reason why studies like this are valuable, even though they're not necessarily clinical studies, because for forensics, you want to be able to look at certain patterns, right? And that brings us back to the images before, when we had all the different types of bullets and what kind of wound pattern they cause. So it's all based on these factors. Now with velocity, you heard me before saying high velocity impact for that shattered humerus and femur in those radiographs before. This is where it comes into play. When you have a low velocity impact, it causes minimal wounds. When you have a high velocity, it could be a large devastating wound. Residual energy of the exiting bullet may generate another penetrating bullet wound. And then, of course, it also depends on tissue type affected and distance from the gun muzzle to the object shot. So these are all factors that affect what the wound will look like in people and in animals. It should always be considered that wounds from gunshot injuries are always contaminated. It's untrue that because the bullet is associated with a high thermal characteristic or high temperature, that they are sterile. That's not the way it works. The bacteria that are on the skin are going to be brought into the wound itself when that bullet on impact hits the soft tissues and goes into the wound. Or creates the wound. It's going to bring in those bacteria from the skin into the area of trauma. And so literally at the moment of impact, you consider it contaminated or infected. And then if it goes untreated, then of course bacteria from wherever, depending on where the wound is, from the environment and also from internally, like intestines, will make the infection worse. So we often consider gunshot wounds emergencies. In terms of lead, like we said before, you have to decide whether or not it's worth extracting the lead from the body, because it's going to cause additional surgical trauma. And so you want to weigh the pros and cons of that. For legal evidence, you are going to want the bullet fragments if you're called upon to do so. Otherwise, if that's not the case, you have to decide as a doctor whether or not it's worth it. Joint wounds can lead to what we call lead arthropathy that we talked about earlier. And infection is most often to happen in hot and humid environments. and in the soft tissues between 0 and 0.5 centimeters from the wound track edge within 6 hours. So within 6 hours is called the golden period. That's for any infection, not just gunshot wounds. The first 6 hours is the period of time usually where antibiotics are not needed, and if you attend to the wound within those first 6 hours, the golden period, then you eliminated the risk of infection. However, of course, most of the time in veterinary medicine, you're not going to see wounds that quick, and I don't think any veterinarian would avoid antibiotics, even if they did manage a wound within the 6 hour time period. It's just too high of a risk, especially for gunshot wounds. So, but the studies have shown that infection rates are higher with hot and humid environments, and also after 6 hours after the wound is created. And then finally, treatment. So we'll talk about the left category, then we'll go into the red, green, and red, orange, and green categories. Death risk is based on wound characteristics more so than the injury circumstances when inflicted, and that's close versus long range, and then more so than the type of firearm itself. So most often it's not necessarily due to the firearm itself that causes the higher death risk. It's how bad is the wound, and that's what we care about in terms of the prognosis for that animal. Surgical management is sought in about 30% of dogs and cats. More so extremity wounds are more common than abdominal, which are more common than head and neck, which are more common than multiple wounds. So in terms of treatment, any veterinarian, of course, knows this, but for those who are seeing this for the first time or want to know how a seasoned veterinarian is going to tackle this, the red category there is what you're going to do immediately. You're going to perform these things immediately once the animal enters your facility and the caretaker or the owner or the trainer or whoever gives authorization for this stuff. You're going to treat the animal for shock. You don't care about the wound in the first couple of hours of tending to that animal. You're placing the intravenous catheter, collecting blood work for baseline, chemistry panel or biochemistry panel, biochemistry profile, and a complete blood count or a CBC. You're looking for any evidence of internal trauma. Radiographs of whatever region you think are affected, but more importantly, if the dog is having or cat's having issues with breathing, then of course you're going to look for the thoracic cavity. If you have evidence of abdominal distension, you're going to have abdominal radiographs, and so just depends on what you're looking for there. Blood pressure checks, electrocardiogram checks, looking for the heart rhythm, intravenous fluid administration, temperature support. Most animals, when they go through the phases of shock, they'll initially be hyperthermic, they then quickly become hypothermic as they go into the more advanced decompensatory stages of shock. Pulse oximetry tells you what the percent oxygen levels are, and of course pain management. Pain management or analgesia can be tricky because analgesia itself can cause hypothermia, bradycardia, slower respiratory rate, and you may already have that in an animal that's in shock. You don't want to make that worse. But pain can also cause those things. Pain can cause shock in animals. And so you need to balance whether or not the analgesia is worth giving right now, knowing those side effects are possible. Do you give the full dose? Do you give half dose? Are you going to give it intravenously so you get quick access? Or are you going to give it in the subcutaneous or intramuscular so you have a slower absorption of the analgesia? It all depends on what you're trying to achieve and how the pros and cons of administering the analgesia are weighed. So that's just a handful of things you would do. There's many other things you can do, like blood gases you can do as well. But this is just to give you an example of in the first hour or two, this is what's going to happen. And these things are going to happen simultaneously. If you have a good trauma team or you are a veterinary clinic that's like a trauma center, you're just used to seeing these things, then your team will be able to hook the animal up to all of these diagnostics, start treatments right away for shock. And even though you are enticed to look at that wound, you're not going to care about it in the beginning part unless there's active hemorrhage or something like that. Otherwise, the wound is irrelevant right now. You're trying to stabilize the patient. For the orange category, you can then, once you get the patient stabilized, you can implement basic wound care, bandaging, collect sample of the tissue to submit it to the lab for culture and sensitivity testing, which will look at what kind of bacteria are growing, if any, how many are there, what types are they, and then what antibiotics are going to work. You're not going to receive the culture results until maybe 5 days or so after submission. So while you're waiting for those results, you will treat the patient empirically with antibiotics based on your best guess. Most often, we're going to treat these animals with a broad spectrum of antibiotics, typically at least 2 of them, maybe even 3, depending on what you're dealing with there. Once the culture sensitivity testing comes back, you can then be more nuanced what antimicrobial or antimicrobials you want to use. You may add more antimicrobials, you may take some away, you may change the administration, maybe you're going to go from injectable to oral or vice versa, so it just depends. Nutrition is huge for healing. We know this now. And so the moment that animal can eat, meaning is the gastrointestinal system healthy enough to take in food, and is the animal mentally, neurologically aware to ingest food, you want to get nutrition started. Or the nutrition has to be through tubes, so a gastrostomy tube, jejunostomy tube, whatever it may be, or esophagostomy tube, or it's going to be in a place that's got PPN or TPN, partial parental nutrition, parenteral nutrition, or total parenteral nutrition, which is nutrition given intravenously. And there's only a few hospitals that do that in the United States, but that's a possibility too. But the point is, you want to start nutrition as early as you safely can for these animals to help with their wound healing. Whenever they have severe trauma, they're in shock, they're critical, the amount of nutrition they need is amplified. And there's actual formulas that we can use to calculate what their caloric deficit is going to be, what their body is going to need in order to start the healing process. You have to make sure they're eliminating appropriately, so urination and defecation. So you have to measure ins and outs usually, and then you're going to follow up from the red column. So you're rechecking values that are abnormal, blood pressure, ECG, blood work, whatever it may be, radiographs, pulse oximetry. You're going to keep checking temperature, and these are things that are going to happen. The red and orange categories are happening back and forth. And then finally, when the animal is stable enough, the green column with anesthesia, surgery, whatever that means, whether you're entering the chest, the abdomen, the joints, it's just basic wound care, whatever it's going to be. The surgery, drain placement, and management if needed, and then continue modifying the plan in the red and orange columns depending on how the patient is progressing. And this is, the red column is happening the first hour or two of entering the hospital. The orange is probably happening later on that day, and then or the next day, but usually that later on that day. And the green may be happening the following day or so when the animal is more stable and ready for anesthesia. But you're always going to be back and forth with these categories, and so this is how you have to think about it when you're dealing with these cases. So I hope you enjoyed this talk on gunshot injuries in dogs. It was well received. We had about 30-something folks in the audience, so they were really interested in ballistics like this, and that was good to see. A lot of the officers there have minimal to no training on the field, and so most of their questions came from how do you perform a chest tapping, what should they have in their emergency bags if they're going to treat animals in the field, how important are things like bandaging the wounds, how do you bandage the wounds. And so I think for the future, if I do this talk again for them, I may make it a much more hands-on lecture, even though it'll be a disservice to them because you really want them to actually physically be hands-on for doing this stuff. But I'll do the best I can by modifying this talk in the future. But for those folks who needed a bit of an overview for trauma like this in dogs, there you have it. And I'll put the more detailed notes in the description below. Thanks for supporting the channel, and we'll see you next time.